Good evening, one and all. This is Dr. Vijay Chennamchetty. Today, we are going to discuss on progressive pulmonary fibrosis, which is most exciting topic. And then, to be honest, to say, okay, for beginners or who doesn't have really great experience in management of ILD, PPF is one entity where it confuses while managing. So now, indeed, it's my great privilege to moderate today's session of progressive pulmonary fibrosis. And we will definitely go into really depth of this topic and ensure that all the dilemmas which comes in managing this patient will be addressed without doubt. Today, but we need to understand over the last decade, our understanding of fibrotic lung diseases has undergone a remarkable transformation. We have moved from viewing fibrosis merely as a complication of individual interstitial lung disease to recognize progressive pulmonary fibrosis as a common disease behavior that transcends diagnostic boundaries. The central question is no longer what is the diagnosis, but increasingly, is this patient demonstrating a progressive fibrosing phenotype that demands timely intervention? I must profusely thank Indian Chest Society and its office bearers, Dr. Amita Naine ma'am and Dr. Rakesh Chavla sir and team for conceptualizing such a unique topic, such highly relevant topic for this evening. Thank you so much, Dr. Naine ma'am and Chavla sir team. And we must also appreciate for the Lupin, the sponsors for this event, because they have done so well in the past 1 week. The webinar information they have marketed in such a way that we have already close to around 1,200 logins at the beginning of the webinar. And we have star-studded panel. I'll introduce them later, but it's my duty to introduce Kapil first. Can I have the slide of Kapil? So Kapil is I cannot no longer, call him as a young talented. He is a senior talented, okay, pulmonologist and lung transplant physician, okay, working with Apollo Hospital, Navi Mumbai. And then more importantly, his skills of, presentation is unique, and he ensures us with his talk on progressive pulmonary fibrosis A to Z, okay, in a crisp manner. I'm sure I'm looking forward to, listen from him. And Kapil, my younger brother, okay, he has, some unique qualities apart from his, oration skills. And then, okay, he has done his transplant pulmonology fellowship from UK, and then he's practicing in India, that predominantly focusing on, end-stage lung diseases, interstitial lung disease, and then transplant pulmonology for the past 3-4 years. Okay, without much wasting time, I would invite Kapil, my dear brother, to talk on progressive pulmonary fibrosis.
Thank you so much, Dr. Chennamchetty Garu, as I lovingly call you. And also thank you so much, ICS, especially Dr. Amita Naine ma'am, Dr. Rakesh Chavla sir, and the entire team. Before I start, are my slides visible?
Yes, indeed.
Okay, perfect. So thank you so very much for giving me an opportunity. And believe me, it's a star-studded panel. So my job is very simple. As Dr. Chennamchetty Garu mentioned that in the last decade, there has been so many new things in, the branch of interstitial lung disease, PPF being one of them. Okay. So my job today is very simple, just to give a very, very brief introduction, touch up on a few points on PPF. And then obviously we've got a star-studded panel in which we will discuss so many points in detail. So my talk today will revolve around the following points. So first, obviously, how do we define PPF? I'll obviously be giving a few personal sort of opinions and points along the way, including dissecting the definition in my own way. What are the entities included? So when you say PPF, is it one entity? Does it entail a lot of things? Briefly, what exactly is the pathogenesis of PPF? Why is it important? How is the management of PPF, in which, I'll be talking about two major antifibrotics. What does data show about both of them briefly? Because we'll obviously be discussing about them in detail. And as Dr. Chennamchetty Garu mentioned in the past, I am personally a transplant pulmonologist. So I'm somehow trying to find ways, to steer the topic towards lung transplantation. So yes, I will be talking about a small connection, which I feel is very, very relevant while discussing about PPF. And in the end, I'm going to be putting in a few personal comments. It might be possible that my fellow panelists may or may not agree with me. Dr. Chennamchetty Garu may or may not agree with me, but these are just my personal comments. And of course, we can have a detailed discussion right in the end. Okay. So let's start off. What do you mean by PPF? So in a patient with ILD of known or unknown etiology, remember, IPF is excluded in this, okay? Who has radiological evidence of, pulmonary fibrosis, PPF is defined if within the past year, there should be at least two of the following three, and you do not have an alternate explanation for the same, okay? So the first point is there are worsening respiratory symptoms. So we are covering the clinical part of it. The second is there should be a physiological evidence of disease progression. So obviously, as we all know in lungs, the lung physiology forms a major part. And third, there should be a radiological evidence of disease progression. So obviously, we've got imaging involved, okay? So in a known or an unknown etiology of ILD, which is not IPF, if in the past 1 year, you've got two of the following three without an alternate explanation, we label this as PPF. Remember, first is clinical, so symptomatology. Second is physiological. So obviously abnormalities or physiological evidence of disease progression. And third is imaging. So you've got radiological evidence of disease progression. Now, what exactly are the points to ponder in this? Number one, obviously, remember, we are not including IPF in this definition, okay? There's obviously been a lot of work, a lot of importance traditionally and historically always been given to IPF. So this is exclusively non-IPF fibrosing ILDs, which we are looking at, okay? Second, and I feel this is a very, very important point, is remember, PPF is not a particular clinical entity, but it is a process. So we do not diagnose a patient as PPF, but we have to understand that this is a process which is happening. And as I mentioned, two of the following three can worsen. So it can be clinical, radiological, or physiological. Now, allow me to slightly ponder a bit in detail about the last two. So what is physiological worsening? What is radiological worsening? There are criteria for it, okay? So in the physiological criteria, we've got an absolute decline in FVC more than 5% predicted within 1 year of follow-up. Remember, this is an absolute decline and not relative decline. Okay, so we are not talking about percentages, but an absolute value. Second is an absolute decline in DLCO. We are all pulmonologists. We know that DLCO is much more specific compared to FVC. So if you've got an absolute decline in DLCO more than 10% within the last 1 year, again, these 2 pointers point towards a physiological evidence of worsening of the disease. And what do you mean by radiological criteria? So yes, there is an increased extent or severity of traction bronchiectasis or bronchiectasis. There can be new GGOs with traction bronchiectasis. There can be the appearance of new fine reticulation. There can be an increased extent or an increased coarseness of reticular abnormality. There can be new or increased honeycombing. And because obviously it's a fibrotic process, we all know it leads to lung volume loss. So there can be an increased lobar volume loss. So these are the 6 criteria or the 6 points. If the patient fulfills this, we have to mention that there is a radiological worsening of the fibrosing ILD. So this is in short what the definition entails. Now, as I mentioned in the past, so when we say that it is a process and not a clinical entity, what exactly entities does it include? Now, this is again a figure which I've taken from obviously Ganesh Raghu sir's article. And you can actually see he's just classified the ILDs other than IPF. So you've got all these different, classification. So first is obviously IIP, second is autoimmune ILDs, third is exposure related, fourth is ILDs with cysts or airspace filling, and obviously last is sarcoidosis. And you can see each of the box, the blue figure actually shows the percentage of this particular entity which is seen in PPF. Now in India, out of this entire box, I would say that hypersensitivity pneumonitis will be one of the most common, which we see. Connective tissue diseases related ILD will again be common, and occupational lung diseases. So we've got a lot of these, unfortunately, who are masquerading in our society as tuberculosis. But these in India, will be the ones which will constitute the main entities which we define as PPF. Now, again, you've got different studies, and I've got this one figure from a Spanish study in which, again, they have categorized different kinds of ILD. And in their study, what was the percentage of this ILD which they labeled as PPF? So again, you can see in this study, the most common, in fact, was autoimmune ILD, followed, of course, by fibrosing NSIB and fibrosing HP, approximately up to 30%. And again, you've got more studies. So these studies, if you can see on the y-axis, the percentage of patients meeting the criteria of progression within 2 years, you can see this was a comparison of 2 studies between IPF and non-IPF. So the first column, you can see up to 59% of IPFs actually progressed within 2 years. And you can see the other diseases is slightly less, especially the study done by Taki et al., in which you can only see 35 to 27 to 24% roughly diseases which progressed within the last 2 years. Now, this is something which I came across, in fact, on LinkedIn today. This is the ProFibro survey study, which is done in India. And this was actually presented as a poster presentation in 2026 ERS. And I'm very happy to say that our dear moderator, Dr. Vijay Chennamchetty Garu, is obviously one of the authors who has contributed to the study. So we are obviously waiting for the final statement of the ProFibro survey. But this was 117 pulmonologists or clinicians who participated all over India. And this was spread across 16 states. And almost 87% of the pulmonologists who actually participated in this. And you can see, as I mentioned previously, 85%. So fibrotic HP was the most common ILD, which, was labeled as PPF. RA ILD was 70%. And you can see that nintedanib was the one which was the chosen or the preferred antifibrotic. Of course, Garu will tell us more in detail, and we are, waiting for the paper of the ProFibro survey. Now, what is the pathogenesis? Now, this is a bit of theory, but in this theory, if I could just point to point number 3, which you can see that a recent experimental study showed that alveolar epithelial type 2 cells were aging. And one of the trigger points for the ILDs to enter into a PPF was actually the aging of type 2 alveolar epithelial cells. That's very important takeaway. Second takeaway is fibroblasts. Traditionally, all of us know in that a fibrosing lung disease, fibroblasts on a cellular level is the most important cell. Again, which was seen in multiple trials that fibroblasts is something which was seen to become aged. I mean, there's an aging process in fibroblasts because of which a process of PPF kicks in. Why is this important? Is because in the future, there are going to be therapies which will, traditionally try to target these two molecules. And so we might have some exciting new drugs in the horizon, which will ultimately lead to a target of both of these molecules. Now, before I actually talk about lung transplant connection, if I could just touch upon the management, and then obviously I'll come back to the lung transplant connection. Now, see, whenever a PPF, an entity of a PPF comes to us, remember, we as pulmonologists should not forget about the basics. Okay, so I've listed all the basics on the screen. Everyone knows this, but still sometimes in a busy OPD, there might be a few points which can be forgotten. So remember, it's very important for us to address the etiological factor of PPF, especially let's say something like HP or something. So antigen avoidance is really important. Educational, we need to counsel and recounsel and counsel and again recounsel our patients. Pulmonary rehabilitation obviously is extremely important, but remember, once they enter into PPF, it has to be a graded rehabilitation and a graded physiotherapy. So it has to once again be evaluated by the physiotherapist. Of course, smoking cessation vaccination is something which we all know. Oxygen. Now, I know all of us are pulmonologists and majority of the audience who have logged in are pulmonologists, but it is remarkable how I have seen patients who have had ineffective oxygen counseling, which is being done. The very fact that these patients have to crank up the oxygen before even attempting a motion or movement is something which is absolutely not explained. And unfortunately, I believe we still need to work more as far as providing proper oxygen support to these patients, and obviously optimization of comorbidity. So it's not necessarily the lungs. You'll have osteoporosis, you'll have sarcopenias, cardiac conditions, metabolic syndromes. All of these need to be revisited. Now, I'm going to be talking about two drugs slightly in detail, which is pirfenidone and nintedanib. Now, remember, both of these drugs, there were some trials which were done in detail, and of course in our discussion we will be discussing these. So first is pirfenidone. So one trial of UILD randomly assigned 253 patients to either pirfenidone or placebo, and this was followed up for 24 weeks. And there was one more study in which 127 patients were actually subjected either to receive pirfenidone or placebo, and this time they were followed up for 48 weeks. Remember, both these trials did not show statistically significant difference in progression or survival or mortality at 48 weeks. Now, it's very important to concentrate on the third point. Remember, in the first trial, pirfenidone decreased almost by 1.6 times the likelihood that the predicted FVC would decline by more than 5%, and almost by 1.9 times the likelihood of percentage predicted FVC, which would decline more than 10%. The relief trial, which is obviously the second trial, both of them also showed it reduced the mean time decrease in DLCO in both both the category of patients. Unfortunately, there was no significant difference in scorings such as St. George Respiratory Questionnaire or the Leicester Cough Questionnaire score or a visual analog scale score for cough. Now, obviously, this was the recommendation which was done in Dr. Ganesh Raghu sir's paper. Obviously, further research is needed for the safety and the effectiveness of pirfenidone in both these categories. Non-IPF ILD manifestations in general and specific types. The second drug is nintedanib. Now, remember, INBUILD trial, which was a revolutionary trial, the number of patients assigned was 663, either to nintedanib or placebo for 52 weeks. And this was obviously analyzed. Now, among all patients, FVC declined in both the groups, but the mean was slightly less in the nintedanib arm. And what was the slightly less? 107 ml. And remember, patients with PPF who received nintedanib had less annual decrement in their FVC if their underlying ILD was CTD related ILD, fibrotic NSIP, or a fibrotic occupational lung disease. And you can see the number which is given. The most significant was for fibrotic occupational lung disease, which was almost 250 ml per year. Now, remember, it showed no statistical difference in all-cause mortality amongst all patients with PPF. Again, this was the final statement given in the trial that we do suggest nintedanib for the treatment of PPF in patients that have failed standard management for fibrotic ILD. And of course, further research work is needed. Now, I am not touching on nerandomilast because that will obviously be covered in detail by all my fellow panelists. And as I mentioned previously, I keep trying to get the topic back to my area of expertise. And what I prefer is, what is the lung transplant connection? Now, remember, in PPF, in the diagnosis, I mentioned a physiological criteria of worsening of the patients. Now, if you see the second column over here, timing of listing of patients for lung transplantation in ILD, you can see that the first point actually mentions the same. It is a physiological worsening of the patient. Look at the absolute decline in FVC by 10%, decline in DLCO by 10%, and a decline in FVC by more than 5% with radiographic progression. What this actually means is, when you are clinically thinking of PPF, you also need to start thinking of referral of these patients for lung transplantation. It's easy to say this, but unfortunately, what we see in practice is something which doesn't happen. And these are obviously the current trials which are ongoing with both these molecules, pirfenidone and nintedanib, in various PPFs and in different subcategory of ILDs. Now, remember my personal comments. Again, as I mentioned in the past, this is what I feel. It might be possible that a lot of my co-panelists and Garu might agree or disagree with this. First is, look, I personally feel that in India, ILD is very unique. We've got our own homegrown challenge. It's not like the West. I know ILD patients who have also received ATT and then they come to us. So it is, in our country, it's very difficult for us to cut, copy, paste some Western guideline and straight away put it. So we need our own guidelines. And I'm very happy, as I mentioned previously, I showed the photograph that yes, a survey has been done. So there is work happening in India with regards to PPF, and we are all awaiting the results of that. We've also got very special patients. Remember, ILD, and as you all know, is one of those diseases in which there's a lot of doctor shopping. So sometimes it's very difficult for us to accumulate data, because by the time there's a follow-up time, your patient has already shifted to a different pulmonologist. So that happens in our country. Again, patients are referred very late to us. So sometimes we talk about etiological diagnosis, we must, but by the time the patient comes to us, they're too unstable. So when we're thinking of, let's say, a biopsy, I'm no longer thinking of a debate between TBLB and cryo or something. No, the very fact that we need to subject this patient to a biopsy, remember, the patient is already too late. Oxygen requirement is quite high. So it's very difficult in our country to completely attain etiological diagnosis. Radiologists and pathologists, obviously, we all know we have a scarcity of both of these who are expert in thoracic radiology and thoracic pathology. We all know what difference a good quality CT scan can do for us and for our patients. The lesser the said about this, the better. Now, DLCO and 6-minute walk distance, all the guidelines mention that we must do this, but the ground reality is it is not being done as much as it should be. In private, it's very difficult for the pulmonologist to have all of this in their own, setup. I can understand institutions, I can understand tertiary centers, but the extent that this is being used in our country, unfortunately, is not what we should be doing. So it is slightly less. We do have lack of clinical scoring. Remember, in PPF, I mentioned 3 things: radiological worsening, physiological worsening, which we have got a proper criteria. But when we talk about clinical worsening of these patients, we are very reluctant, unfortunately, to use proper scoring system, so for us to have an objective sort of an evidence. Otherwise, we leave a lot to a subjective sort of, scoring. And obviously, antifibrotic blanket therapy is something which happens. Remember, the patient has seen 10 people before they come to you. Patient is already on a combination of nintedanib and porphyridone, and then the finally patient lands to you. So obviously, this blanket therapy is something which has been going on. Variable intolerances, I put my hand up and say, in my practice, less than 5% of my patients completely tolerate 2400 milligrams of porphyridone. I don't know what my fellow panelists will have in their practice, but it's very difficult for our population to tolerate these dosages. I'll be very interested to listen to what my co-panelists have. And we want to be a splitter in our practice as far as ILD is concerned, but all of you will agree with me. The ground reality is all of us become lumpers, So while we want to attain a splitting sort of a practice, unfortunately, we all become a lumpers in our practice, and that is something which all of us need to ponder about, and which is why it's very important that we are having this presentation. And thank you, ICS, for providing such a platform. That's it from my side, and up to Dr. Vijay Kumar Chennamchetty Garu.
Kapil Bhai, it's a fantastic, comprehensive briefing about progressive pulmonary fibrosis. And then the beauty is, the last slide, okay, which has given a wonderful overall picture of what is happening in India, and then what are the challenges that we are facing. Of course, before saying anything, comments on that, okay, I would love to take all these, points which you have discussed with our panels as well, and then we'll conclude at the end. And it's absolutely an honor, okay, to introduce my distinguished panelists who are from across India. Okay. So, Dr. Ruchi Dua. Okay. Welcome, Dr. Ruchi Dua. Okay. Dr. Ruchi is an eminent professor from AIMS Rishikesh, and she has her interest in pulmonary function tests, NIV, EBUS, intervention pulmonology, and Madam is MD DNB, EDRM, and Fellow of WABIP. And she has close to around 30 presentations and 50 publications. And awards to mention many, to hear briefly: distinction in biochemistry, second Young Scientist Award in NAPCON 2017, Best Paper Award in NatCon 2022, numerous fellowships and memberships to her cadre. Welcome, Dr. Ruchi. Absolutely an honor to have you today in the discussion. And Dr. Arun Sampath, a good friend of mine with close to around 2 decades of experience, MD, DNB, European Diploma, FRCP Glasgow, FCCP, FA. Yes, sir. Welcome, Dr. Arun. Arun is a senior consultant from MIOT International, Chennai, with 16 publications, 7 chapters, and 10 abstracts. And he is a section editor or reviewer of Journal of Association of Pulmonologists, Tamil Nadu, MEDNO, and section reviewer of Indian Journal of Tuberculosis, member, secretary, MIOT Ethics Committee, formerly executive committee member, Association of Pulmonologists of Tamil Nadu. Welcome, Dr. Arun. Arun is exceptionally known for his expertise in, ILD pathobiology and multidisciplinary diagnosis. Looking forward for a wonderful contribution from you, Dr. Arun.
Yes, sir.
And Dr. Neha. Welcome, Dr. Neha. Dr. Neha is MD Pulmonary Medicine. She's a gold medalist, fellow of ICS, and currently working at Indore as a Medicare hospital senior consultant at Medicare Hospital and Research Center. And she is also a director at Care Clinic Indore. And she has done her observership in interventional pulmonology and critical care at Singapore General Hospital, Singapore, and ex-consultant at various multiple centers like in Mumbai. And she's a recipient of Academic Excellence Gold Medal for outstanding performance in MD. and recipient of Young Scholar Indian Chest Society Travel Grant for European Respiratory Congress Paris 2018, several international and national publication, and Dr. Neha is known for her significant contributions to the management of CTDs, associated ILD, and progressive fibrosing lung diseases. Her evidence-based approach and clinical insight have earned tremendous respect among peers nationwide. Welcome, Dr. Neha. And Dr. Arindam Datta, good friend of mine. And Dr. Arindam is a MD EDARM and currently working as a consultant pulmonologist in its super specialty, Kolkata. And he's also visiting consultant at Intervention Pulmonology Center, Chittaranjan National Cancer Institute. Major achievements include multiple publications in national and international journal, ICS member for HERMES, and he is one of the country's leading authorities in interstitial lung disease and pulmonary fibrosis for his outstanding academic contributions, multidisciplinary expertise, and committing to advancing patient care through research and education. And welcome, Dr. Arindam. And I'll take one more minute before Kapil introduce me. Can I share my slide once?
Yes, sir.
One slide I want to share. So today is what a honor for me, on the day of Guru Purnima. Okay, it is absolutely sheer honor for me, to moderate this session. I learn a lot from all over, ICS members, particularly today. In next probably one and a half hour, I'll be looking forward to learn from all of you, my dear panel, and then whatever questions you are going to delegates, whoever attending, okay, there are close to around 2,000 plus attendees now. Please post your questions. Will be on this auspicious day. It will be a privilege for me to get it clarified from the lovely panel. So to read this, Dhyana Moolam Guru Murtihi, Puja Moolam Guru Padam, Mantra Moolam Guru
Sorry
Vakyam.
for interrupt
Yes.
you. Your screen is visible, but उसमें Zoom का share दिख रहा है. आपने कोई PPT slide share किया है क्या?
Yeah.
Okay, but ये
It is not visible?
No, sir, it's
No,
not
sir.
visible.
Oh, right. Now?
No,
Not
No,
yet, sir.
nothing is visible?
no, sir.
Just a moment, just a moment.
First, open your PPT slide and then share the screen, sir.
One moment. Allow to share window, huh?
Yes. You need to share your entire screen, sir.
Right. Now, is it visible?
No. Yes,
Now
now
it's
it's visible.
yes.
Yeah. So, on this, auspicious Guru Purnima day, okay, I would love to, convey all of you my best wishes. And then there is a Sanskrit slok from Adi Shankaracharya. Okay, Dhyana Moolam Guru Murtihi, Puja Moolam Guru Padam, Mantra Moolam Guru Vakyam, Moksha Moolam Guru Krupa. That the meaning of this is, the Guru's form is the focus of meditation. Guru's feet are the foundation of worship. The Guru's words are source of all sacred mantras. The Guru's grace alone leads to liberation. And then it is the alone, this is the one which is going to give us enough wisdom to ensure that we deliver nothing but the best to our patient. Okay. You can I can stop sharing. Right. Okay. And then over to Kapil.
So before actually we start the question and answer session, and with Garu moderating, I think it's an honor for me, to introduce Dr. Vijay Kumar Chennamchetty. He is, of course, a loving elder brother, not only to me, but to a lot of pulmonologists all over India. He's a senior consultant, interventional pulmonologist, and sleep disorder specialist in Apollo Hospital in Hyderabad. And of course, I mean, the more I speak about his qualifications and everything that he's achieved, we'll be here till tomorrow, obviously. But best thing about Sir is never shies away from imparting knowledge, especially on all sorts of academic programs and academic schedules. And it's an honor for me, and it's very, 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 we are very happy that Sir is a moderator in this topic, and he will get some spice into all the questions, and we love the way he moderates. Over to you, Sir.
Thank you so much, Kapil. Bye. Thank you so much. Right. And rather than, now we'll jump into, we have already close to around 2,000 people watching us. And then we have designed a pre-designed a flow of questions so that we will not leave anything in PPF to be not covered. So my responsibility is to quickly to go ahead and then start asking questions to my dear panel. So Dr. Ruchi, ma'am.
Yeah, sir. Yeah.
Yeah. Hi,
Thanks
ma'am.
for the
Welcome once again.
kind introduction. Yeah.
Right. Ma'am, could you please, help us? I mean, how has our understanding evolved from classifying ILDs by diagnosis to recognizing progressive pulmonary fibrosis and as a progressive disease behavior? And why is this shift so important in clinicians? Can you please?
PPF is not exactly a kind of a diagnosis. It's kind of a trait of this disease. And we can say, once we use this term PPF, it implies two things. One is the prognostic part, because PPF has been seen to behave as IPF, which we know is a chronic disorder and has a limited lifespan for that matter. So one reason is the prognostic similarity it shares with IPF. And second reason can be the management part also is depending upon this term. Like for PPF, now we know that apart from whatever treatment specific to the etiology we are offering, we also have other options like the antifibrotic. So I would say both prognostic and management.
So thank you, Dr. Ruchi, for that, brief and then detailed explanation. So what is very, very important is we all need to understand that PPF can exist with any other disease entity. It is not a disease by itself, but that kind of phenotype is very, very important to identify, and then thereby we can prognosticate, because that's where the point where the moment you identify, the early you identify this phenotype, the way we manage changes. Unless we identify, it is very, very difficult to pinpoint the diagnosis and then manage accordingly. That's what Dr. Ruchi says. And next, Dr. Arun. Hi. So, Arun, can you please, brief me about, yes, Dr. Kapil has covered it, but again, in the interest of, some young pulmonologists, can you please brief me about pathobiology of self-sustaining fibrosis?
Yeah, thank you for the wise introduction, sir, and my pranam to all of you. So, yes, already Dr. Kapil has given a brief about the biology. So, what we are talking about this progressive pulmonary fibrosis is in the already existing interstitial lung disease, where that inflammatory pathway is moving on to the fibrotic pathway, and where there are certain important factors we need to know that as apoptosis is changing on to the senescence, as Dr. Kapil said, that more and more of aging of the cells And then the fibroblast pathway is moving on to more and more of myofibroblast, and which lead to the aberrant deposition of the extracellular matrix. And here what exactly happens is a sort of auto looping. So the extracellular matrix is more of an aberrant pathway where it itself brings more and more of myofibroblast and other fibroblastic foci. And subsequently, what happens is the mechanotransduction pathway. So herein all the factors which we need to know about that, such for example, the TGF beta, PDGF, CDGF, and the lysophosphatidase. Why I am talking about all these factors? Because these are all the factors which we are targeting right now with the newer medications, and we will be talking more and more in the panel discussion. And also, if you see the prostaglandin pathway, PGE2, which is actually an anti-fibrotic. Surprisingly, for some reason, this prostaglandin pathway is getting suppressed in all these fibrotic pathway, and hence on one side there is a pro-fibrosis, on other side there is less anti-fibrosis. So we can target on either side and to find more and more biomarkers and also the treatment aspects. So once the trigger starts and then fibrotic pathway moves, then it exactly behaves like an IPF. So that is what the majority of the studies, we are taking the results from the PPF and then moving on to PPF. So the biology itself is moving on from pro-inflammatory to pro-fibrotic, and then we are actually seeing similar to the IPF. So that is why we will need to discuss more and more today.
Thank you, Dr. Arun.
Yes,
so what Dr. Arun is trying to convey you, my dear friends, is we need to remember, okay, somewhere between around 2005, 2006, there was a study called Panther study. What is Panther says? Panther says it's a triple therapy, that is around using steroid, immunomodulator like azothioprine, and also NAC. This triple combination, when given in IPF patient, the study has to withdraw or stop in the middle, because the patients who were put on this triple therapy, the immunomodulation for IPF doesn't contribute for a favorable prognosis. But remember, my dear friend, the same thing, the pathobiology, if you see in PPF, because the majority of times, as Dr. Kapil mentioned very clearly, it can be hypersensitive pneumonitis, it can be RA-associated ILD or other CTD-associated ILD, where the crux is you have to immunomodulate. You have to ensure that immunomodulation is at the perfect dose so that the overall progression of the disease can be curtailed. This is what Dr. Arun wants to communicate. And let me invite Dr. Neha for her first question. Dr. Neha, which patients with fibrotic ILD should make us think this patient is likely to become progressive even before objective deterioration is evident? Dr. Neha? So, Kapil, you would love to take that question?
So just...
So what is the question is very, okay, is very clear. How to predict which patients may tend to deteriorate. Okay, that is the question. Yeah, over to you.
So if Neha doesn't want to answer, if I can answer this.
Yeah, please.
So yes, so
Neha is not there now.
So there are certain diseases, obviously, amongst the fibrotic ILDs, there are obviously certain diseases which will have a predilection to progress more as compared to the others. Now, in this, the question is which patients will make us think patients likely to become progressive even before objective is up. So your baseline diagnosis is going to be extremely critical and extremely crucial. Okay. So now, for example, certain autoimmune diseases, especially myositis induced, let's say ILD, which you've got. So when you diagnose this patient with these diseases, you know that there is a chance that he will progress rapidly as compared to, let's say, the other conditions. Certain occupational lung diseases, I would like to mention, something like silicosis or something in our country will also rapidly progress as compared to, let's say, a coal workers pneumoconiosis or something. Fibrotic HP, unfortunately, it's very difficult for us to categorize it and put it into a certain basket, whether it will, progress rapidly or not. I am on the fence as far as HP is concerned, because we see two extremes in this diagnosis. One subtype will really progress, but the other subtypes will hold on. So I am not very comfortable in putting this. So I will say CTD, I'll say some particular occupations. I'll also see fibrotic NSIPs, which will have a predilection to progress rapidly as compared to others.
So very clearly, as Dr. Kapil mentioned, okay, so those patients who present, when they are presenting itself, their forced vital capacity is very low, or DLCO is very low, or they have a radiological background of extensive fibrosis or honeycombing visible, and those patients, particularly systemic sclerosis kind of patients, and myositis profile positive patients, these are the patients, they tend to deteriorate rapidly. So we need to identify them, and then closely these patterns, once we know, it makes a job that that these patients have to be monitored very closely. Dr. Arindam, hi, welcome. So, can you please enlighten us, what is the most practical definition for routine practical use for defining progressive pulmonary fibrosis?
So, first of all, I would like to thank you for the very kind introduction and such a crisp presentation so far. So, what I would like to do is that it's sort of dynamic process, okay? Because what we are looking at is not a particular disease; it is a dynamic process. It is a behavioral pattern of the disease we are looking at. So, I would be happy to keep the approach dynamic too. So, as far as the diagnostic is concerned, for all the clinical purposes, I would like to stick to the ATS ERS criteria of 2022. But as far as the pragmatism is concerned, as far as more practical day-to-day practice-oriented measures are concerned, I would like to go by the expert consensus, because it is much more pragmatic, it is much more practical, and it puts the multidimensional progress in the picture, and also the indices we are looking at are much more clear over here. Like the objective verification is much more easier here due to the importance of HRCT and all. MDT, which is a standard of care nowadays, has been taken care of in this expert consensus. So if particularly we are dealing with patients with CTD, ILD or something like that, we can have our rheumatological colleague to help us with that, the disease behavior or a disease pattern and exact activity of the ongoing disease in the background, that can be taken care of. So whether we would be more on the side of the immunomodulators or we would be aggressively going for the antifibrotics, those decisions can be taken as a team. So I would like to go by the expert consensus for a monitoring purpose.
So thank you, Arindam, for that crisp response. But I would love to add to a couple of points to whatever Dr. Arindam has contributed. So, my dear friends, okay, please understand this is something which cannot we cannot assume that one size of should fits for every patient. That is perfect thing that I agree to Arindam. But if you look at the ATS ERS criteria, there is a 5% drop in FVC and a 10% drop in DLCO as an objective evidence. Radiological progression. If you look at the radiological progression, it is sometimes very, very challenging to compare the scans, because scan may be not of great quality, or the patient would have lost the previous scan. These are the practical issues. But again, what can be done in the routine practice is take your scans to the radiologist, and then who is the and the radiologist should be an expert in diagnosing interstitial lung disease. That is more important. He should be a thoracic radiologist than a general radiologist. So we are fortunate enough, I don't have hesitation to say, at Apollo Jubilee Hills, Hyderabad, we have Dr. Surender and then Dr. Anjani. They help us very well in labeling whether there is an extent of fibrosis have increased drastically or not. They also use some softwares which are like they help us in scoring how much extent of fibrosis is increased when compared to the previous scan. These are the, I think, practical points which we should combine in our day-to-day practice to label the PPF for a pragmatic reference. And Kapil, with your permission, can I ask Dr. Neha? She joined back.
Sure.
Your question, right? Dr. Neha, welcome.
Yes.
Yeah.
Yes.
So should we really need to wait for that greater than 10% FVC decline before we label it as a PPF, or what are your thoughts?
Sir, so thank you, sir. If the patient is showing worsening of the symptoms, and if the patient is having radiological, progression of the disease, then I think we should not just wait for the numbers. But even if a patient with a stable FVC or a stable DLCO, if the symptoms are worsening, and even if there is radiological worsening, we should not wait to label it as a progressive pulmonary fibrosis patient.
Right. So as per the ATS ERS criteria, so out of 3, we should have at least 2. So if the FVC or DLCO is stable, rather than if clinical symptoms are worsening and radiological is worsening, those 2 becomes important determinants to label it as a PPF. Thank you, Dr. Neha. That's wonderful. And welcome back. And now we'll jump into the second round of questions. Dr. Ruchi, so what are the take-home points from landmark findings in InBuild trial?
So, InBuild trial was a trial which investigated nintedanib, which is a TKI, for patients of PF-ILDs, that is a progressive fibrosing ILD, which was a terminology previously used for PPF. Right. So we already had previous trials which were evaluating nintedanib in IPF, and this was a trial which evaluated it in non-IPF progressive fibrosing ILD. And it was landmark in the sense that in this RCT, it was shown that nintedanib, it reduced the decline in FVC, which was the primary endpoint of the compared to the placebo. So in that term, that it established the basis for giving antifibrotics in patients of PPF.
So for audience who are listening, so we always need to remember what is the evolution of guidelines, what is the history, what are the landmark trials. So as Dr. Ruchi very clearly mentioned, please understand the antifibrotics was first introduced to control the fibrosis progression in IPF only. Later, eventually, what has happened because of with the kind of trials like InBuild and Census. So these are the trials where which made us to treat the fibrosis in non-IPF related ILDs as well. And Kapil also mentioned in one of his slides, close to around 107 ml prevention of drop of FVC when compared to placebo. That is a huge for a IPF patient or a PPF patient, or whichever patient who is having fibrotic ILD. If a drug is influencing and then stabilizing 100 ml more FVC, that means we are giving his life back. Okay, that's what. And then thank you, Dr. Ruchi, for that crystal clear explanation. Dr. Arun.
Yes, sir.
Please enlighten us on similar placebo decline in InBuild and impulses. What is your take on that?
Yeah, if we see, sir, as we already discussed, in both these trials, if you see the placebo, on one side it was only nintedanib, and the other arm they were treated with other conventional treatment. They are not actually placebo. We can say they're already on immunosuppressants and other therapy. And if you compare the FVC decline over the 52 weeks, and in the placebo, it it's around, say, about 180 to 240 ml, there is decline in the lung function. So this reinforces the idea behind this today's topic is PPF, that it's rather not to wait for even 52 weeks to define a patient to have a progressive fibrosis. And actually, if you see, the PPF is actually a retrospective thought that last 12 months how the patient progressed rather than being prospective. So in such scenario, even the placebo arm tells us that the wastage of time to introduce the fibrotic agent, antifibrotic agent in this patient can lead to further decline in the lung function. But however, I just want to even ask other panelists also here, in all these inbuilt and these impulses, trials and everything, if we go in detail, the baseline demographics, the mean FEC is around 80%, is 75 to 80%, which I want to take it as a pinch of salt, whether we need to take these trials into our clinical practice. Most of the time, we are seeing with the FEC less than 1 liter or 30 to 40%. Now, the decline of 5% or 10%, I'm not agreeing with our clinical experience, where we need to see in more detail with the clinical close follow-up. I can rather say close follow-up, and the initiation of the appropriate therapy should be at an appropriate time rather than waiting for some 12 weeks to define our patient to have a progressive fibrosis. So this I want to specifically emphasize.
Wonderful.
No, I completely, wonderfully put.
Wonderful.
I would love to bring an analogy here. So what Dr. Arun wants to convey here is, so I have 10 lakhs and Kapil is a big man. He has, 1 crore. So that same 1 lakh rupees, okay, if someone is asking 10,000 rupees from me and the other person is asking 10,000 from Kapil as well. It is a relative thing. In India, okay, we see patients with pretty low FVCs. By the time the patient comes to you, the probably, as I completely agree with Arun and Kapil, the practicality is probably majority of times 30%, 40%, 50% of FVCs. So that's why the drop in, yes, of course, they labeled it as a percentage, but probably, I think, maybe in future, we'll have a new definitions when the FVC at presentation is low, probably even the trajectory, the point at which the clinical divergence occurs should be probably, even if it is 3%, 4%, probably we should take it into consideration for labeling it as a PPF. That's wonderfully put, Arun. I totally, what a practical approach you have shown us today. Really appreciate. Dr. Neha, yes. How to interpret pirfenidone evidence in progressive pulmonary fibrosis?
So, pirfenidone is a wonderful drug, and it's been in use for many years now, even much earlier than nintedanib, and it has been shown to, it has shown remarkable improvements in patients with IPF and even with other ILDs. We we published one paper on that. As far as progressive pulmonary ILDs is concerned, the data is not very much robust as compared with nintedanib. So there are various trials which have been done with pirfenidone in patients with PPF, like Relief trial, which Dr. Kapil has already spoken about. There is one Trail trial which has been done in patients with RA-ILDs. And there are certain few other small trials which have been done on patients with chronic hypersensitivity pneumonitis. So pirfenidone has shown a reduction in decline in FVC in such cases, but these studies are very small in size. They were not done, they were terminated prematurely. So the
Right.
ATS ERS guidelines, they don't recommend pirfenidone per se as the first line of therapy in patients with pirfenidone PPF. But yes, in cases where nintedanib is contraindicated or where there is poor tolerability with the nintedanib group, yes, pirfenidone can be given to such patients.
Yeah, thank you. Thank you for bringing in that clarity. Dear friends, please understand, in PPF, So ATS ERS guidelines very clearly mention nintedanib is scores superior because it has got phase 3 evidence, whereas for pirfenidone, it is only phase 2 level of evidence. And Dr. Arindam, yes, now the most challenging question for you. How do you score nintedanib versus pirfenidone in PPF?
So to me, it is not versus, it is out of them, which one? Okay, so
Right.
they are more of a complementary, but I would like to say they are complementary but never interchangeable. Okay,
Right.
so they are not competing with each other, because although the
I
data
think you
so
have
far
to
generate,
keep your phone vertically because it, or
yeah, yeah.
else you have to stop that, switch off that screen reversal thing will be there, na? Because you are almost 90 degrees
Yeah, your image is
perpendicularly
coming
seen here.
vertical, Dr. Datta. You'll have to do it
Okay,
horizontal.
okay.
Yes.
Just
Yeah, you are perfect now. Right. Because
okay. So the
suddenly
thing
my
I was
all
talking,
audience have started seeing like this.
sorry for that.
No problem.
Uh, so the thing is that what I would like to say that
Yeah.
although the data so far, as already discussed by the esteemed panelists, that the data for pirfenidone, although promising, is not robust, is not a homogeneous data. It is much of a heterogeneous data.
Right.
But still, there are promises shown in a certain subset, certain cohort of patients like the fibrotic HP or uh, unclassifiable ILDs and all. So in these cases, this pirfenidone can be used if only more robust data for it. And also there is intolerance of nintedanib. So the patient who are having more of gastrointestinal side effects and all, and also the lifestyle of the patient. If the patient is having more of a frail gentleman whose diarrhea and all will cause more problem, vis-a-vis a person who is a uh, suppose a farmer or someone who is more sensitive to photosensitivity, who is more prone to photosensitivity. So we need to take this into consideration, and
Right.
that's all for now. As of now, the data supports, if you ask me, that if you have a solid data, that is only for nintedanib. But with years to come, I believe there will be more data to either accept or refute the pirfenidone. Till then, we need to just customize it from a case to case basis.
Yeah, what Dr. Arindam clearly mentions is when practically when we want to pick nintedanib versus pirfenidone, so it is very clearly mentioned if we are handling a patient of IPF, yes, pirfenidone and nintedanib both can be used, but in PPF, it is very important to understand. Okay, nintedanib O scores. We are just reiterating because it is the most important point to that we can use it in clinical practice. That's why I'm reiterating one more time. But we should also remember that what is a disease context, whether the patient is tolerating the medicine. That's more important. Sometimes that can be 10%, 15%. Okay. How much ever it may be, if the patient is not tolerating nintedanib, then probably those are the patients where we can pitch in pirfenidone and ensure pirfenidone is well tolerated. I have also seen sometimes when nintedanib is not tolerated at a full dose, when pirfenidone is not, being tolerated at a full dose, there is sometimes we may end up, but this is not at all research proven. We can combine both of the drugs as well. But if you ask me what is the evidence, there is zero evidence so far for combination of nintedanib and pirfenidone. But there is a game changer that is going to come in next 4 months, 5 months in India. That is nerandomilast. That is going to be a game changer where there is enough evidence, even if the patient is using nintedanib or even if the patient is using pirfenidone, we can add nerandomilast to it so that the clinical PPF patients can be stabilized to a far extent. Over to Kapil. Kapil, Tell me, yeah, okay. We have spoken over the past 10, 15 minutes about a lot of evidence and then what are the trials. Can you please conclude who merits immediate antifibrotic treatment?
Okay.
Now,
Sir, Garu, I'm going to keep it very simple, very straightforward. There'll be two
yes.
category of patients who will warrant antifibrotics. First category of patients will be a diagnosis of IPF, which is idiopathic pulmonary fibrosis. We can talk about all the criteria, everything, but any IPF, you have to give antifibrotic. That's number one. Second category of patients is when you've got a fibrosing ILD patient who is worsening, who, despite adequate management, worsens off and enters into the clinical entity or spectrum of PPF, you go ahead with an antifibrotic. This is not a question about choice or whatever. You give an antifibrotic. Obviously, as all my previous speakers and Garu, as also you have mentioned, the choice can be a very individual. It can be perf, it can be ninted, and it can be a combination. But you have to understand that there has to be an optimization of the background treatment. And despite that, if worsening, you go for an antifibrotic.
Fantastic response. For to make it, much more clear to the audience. So guidelines mention you call the patient 3 months, 4 months once, or 6 months once, and then do an annual HRCT and all those things. But my dear friends, don't wait for 6 months or 1 year. Okay, ensure. So I have a small practical tip which I use for my patients. What I do is my patients, I ask daily to perform 6-minute walk test at home, but they will be counting 6-minute steps. How many steps? How many thousands of steps? How many hundreds of steps they will be doing within 6 months? And then they will be monitoring the chart. And then they will monthly reporting to my physician assistant, this is the status. And at any point of time, I tell them that if there is a dip in 10% of steps. Example, if my patient is doing 2000 steps in probably in 6 minutes consistently, and one fine day or one fine week, there is a dip to 1800 or 1750 kind of thing. There's a 10% dip. This is what I use in my practice. So don't wait for the classical guidelines to be implemented in practice. This is what the last slide of Dr. Kapil mentioned in his talk. We have to ensure to catch hold of the patients at the trajectory level, the division of the moment they start, behaving towards progressive pulmonary fibrosis, we have to pick them and then put them on antifibrotics. Thank you. And Dr. Ruchi ma'am, now we will move on to practical management. Okay. What is the immediate strategy once progress is recognized, ma'am?
Once we have progressive fibrosis documented, so one very important thing you always have to consider is that the treatment according to the underlying etiology has been standardized. As you also pointed out, sir, and Dr. Kapil also pointed out, that is one of the most important things. That if you have a CTD-ILD or you have a HP, the underlying treatment for the disease has been started, has been optimized before we think of adding any further drug for the progressive. Obviously, not waiting too long is an important message which we have already given to the people out here, right? And that would be the first part. And obviously, the monitoring would include the clinical symptoms, the lung functions, as well as the radiology, which we have already talked about. So optimize first, and then think of adding the treatment for PPF would be the, I suppose, the take-home message out there.
That's Dr. Ruchi, you have brilliantly put. Okay, we have to ensure once we identify a patient who is in progression, it's as Dr. Ruchi clearly mentioned. Okay, we have to ensure to revisit the diagnosis and reassess the antigen exposure. Whether I'll tell you one clinical scenario, my dear friends. ANCA-associated vasculitis associated ILD, though it is very rare in practice, what happens is ANCA may be negative in the initial, because initial phases, maybe a year, 2 years, okay, ANCA may be negative, but a patient will be having almost a IPF-like picture. Okay, in these patients, okay, you have to identify, resend the ANCA testing. Sometimes it turns positive, then they are the patients where they rapidly progress. This kind of behavior will be seen with a lot of other patients. As Dr. Ruchi nicely mentioned, And if there is a chronic fibrosing hypersensitive pneumonitis ILD, there's a fair chances that the antigen is constantly the patient is getting exposed to it, and then the underlying autoimmune features like probably autoimmune ILD, SLE, or Sjogren's, whatever it is. So we have not yet optimized the immunomodulation. We have to ensure that we have to immunomodulate appropriately, and then these patients. And then the other most important thing, my dear friends, there are sometimes what happens is these patients may not have they may have an exacerbation of ILD, like from infections, like influenza can be the cause, or it can be, recently we have a RAILD patient, young fellow, who presented with, sudden worsening of symptoms and fever. We identified MRSA as a cause of, deterioration. 1 month down the lane, okay, we could stabilize this patient and then brought him back to his baseline FVC. So that's why we have to be very, very specific in identifying what is the trigger for this progression and then treat it accordingly. And Dr. Arun, may I ask you, the immunosuppression and antifibrotics, do you use it sequential or do you combine it?
Yes, sir. If I am allowed, I'll just add on for the previous question.
Yeah, please.
So, as you rightly pointed out that if we are not dealing IPF, if we are not dealing a clear-cut case with exposed antigens or something, we are not able to identify the underlying causative agent. Even if the autoimmune panel and everything is negative, you must just keep in mind that these patients should be followed up after 6 months or so with a repeat panel. And as you rightly pointed out, there is a timeline. Sometimes the serum is picked up later than the initial findings. And for this question, sir, I would rather categorize my patient of all these non-IPF patient as three category. One, the patient is in predominant inflammatory phase. Second, inflammatory and fibrotic phase, or predominant fibrotic phase. I just classify them first. And then if the patient is on predominant inflammatory phase, for example, the CT findings is showing ground glassing or NSIP pattern, or the patient is having other evidence of inflammation like arthritis, uveitis, something else, or the patient is sarcoidosis or something. So I would rather lean on into a immunosuppressant. On the other end, if the patient is typically going into a fibrotic stage with a feeling of all these parameters trying to say that the patient is progressing, I would definitely stick on to the antifibrotic agent. And in between, immunosuppressant and addition with the antifibrotic, which I will have some leeway with the close monitoring every 3 months at least.
Correct. No, wonderfully put. Again, practically, okay, you have said very, very clearly, if it is predominant inflammatory, okay, identify the immunomodulation at a right dose. And if there is a predominant fibrotic, okay, you have to manage. And inflammatory plus fibrotic, okay, both together we have to add simultaneously. So what is very, very important to the panel is, to the audience is, so we often, I will not hesitate to put you boldly right in front of, I know this is getting recorded, this is there for years to come. I don't have any hesitation to say that, okay, you people, okay, particularly those who doesn't have experience in ILD management, they give 500 mg of mycophenolate twice daily, or once daily, or they hesitate to put on rituximab but appropriate doses. Okay, or we have managed ILDs with cyclophosphamide as well. Of course, there is not robust data nowadays. Rituximab definitely overscores cyclophosphamide usage in fibrotic ILD progression. So, my dear friends, if you are in doubt, do not hesitate to take the expert opinion from either your colleague who has much more experience, or talk to the rheumatologist. Go to the rheumatologist OP chamber, sit with him. This is what is the tough situation I'm facing, and then optimize the immunomodulation. The maximum dose that anyone can take mycophenolate, we can go up to 3,000 mg. but at least most of the times 2000 mg works very well. Don't give suboptimal therapy, because suboptimal therapy will lead to facilitation of fibrosis, okay, because you are not controlling the inflammation. Inflammation, which is there for months together, will eventually turn into a lot of fibrosis. So be cautious, take the help of your colleagues. And Dr. Neha, right. Another very, very important question in practice. It is, yes, very tough situation for you. Okay, but again, with your expertise, I'm sure you are going to throw a wonderful light on this. Where should I introduce antifibrotics before the patient fits into PPF criteria? Is there any place where I can add antifibrotics upfront in PPF, in CTD ILDs and then non-IPF ILDs?
So, sir, it is an extremely valid point. All those guidelines, the ATS ERS guidelines, they do not recommend positioning of antifibrotics before the PPF criteria is fulfilled. But as we have also previously discussed, that we have to identify patients who are at high risk for progression, like patients who have an extensive fibrosis or UIP pattern on baseline. If there is rapid radiological progression, there is high risk of fibrotic HP or unclassifiable ILDs, and the patient is showing progressive disease despite of optimal management. And so all these patients, we should not wait for that 1 year follow up or 1 year time interval which the guidelines have given. I think in those cases we should not have a therapeutic inertia to initiate them on antifibrotic therapies. We should be very vigilantly watching these patients, and if these criteria are fulfilled, I think we should go ahead on adding antifibrotics.
Yeah. Yeah, I'll add, with your permission, I'll add some more important points. See, those who have a baseline extensive fibrosis, even if they are, clinically stable, particularly I was going through the ERS guidelines, they clearly mentioned, yeah, they also address this issue, Dr. Neha,
Yes.
for information. So what happens is when someone is having, extensive fibrosis or extensive honeycombing or very low FVC at presentation. Of course, they haven't classified at what FVC to introduce, but if they are having, more symptoms at presentation, less FVC, less DLCO, and then they also quoted one important thing like in patients with systemic sclerosis ILD and also RA-ILD, when there is a honeycombing, they also, when we follow up without antifibrotic, there's a fair chances they deteriorate rapidly. We should not
Yeah.
let the PPF definition to establish in them.
Yes.
These are the patients where we should catch hold of them and then start antifibrotics upfront.
Absolutely.
Thank you, Dr. Neha. Right. Arindam bhai, right. So when to continue, when to escalate, when to combine, or when to switch therapy?
So I think this thing has already been discussed. So the first thing I would like to say that once a patient is in overtly symptomatic phase, before jumping on to make a diagnosis of PPF, we should rule out the mimickers first.
Yeah.
So once the mimickers are taken care of, infection has been taken care of, other comorbidities like the pulmonary arterial hypertension and all these things are taken care of, then only we can reassess the patient and to decide whether to go for escalating the immunomodulators, or if there is a fair chance of infection being exacerbated by the immunomodulators, then we should, and the fibrotic component is also quite predominant, then we should downgrade the immunomodulation and with the proper antimicrobial coverage to start the patient on antifibrotics. Okay.
Right.
And it is on actually a case-to-case basis. So we can again, after some time, we can once we see that the infection has been taken care of and there is suggestive of active inflammation, like you were telling about that uveitis and all of those things. If there is any evidence of active inflammation, then we can think of adding the immunomodulators at a later stage after controlling the infections and all. So it is taken care of on a case-to-case basis. There is no thumb rule that you just do this. So the patient comes, you give both the immunomodulation and everything in the armamentarium. That is on a case-to-case basis. If I am having a patient who is in a severe state of exacerbation or who is in a very poor lung health, I won't hesitate to use everything in my armamentarium, because 10% is too big a chunk to lose of the lung function.
Right, right. Thank you, Dr. Arindam. So, Kapil bhai, okay, can you please summarize in 2 minutes what has happened, in the past 10 minutes regarding treatment algorithm?
So treatment algorithm is a simple stepwise approach which you should follow. I believe step number 1, when a patient of ILD walks into your clinic, try to get to the etiology. That should be our first step. Step
Right.
number 2, as Dr. Arun sir clearly mentioned, I think it was a beautiful, practical ground reality which he mentioned. Try to categorize the patient into one of the 3 columns. Number 1, inflammatory subtype. Number 2, predominantly fibrotic subtype. Number 3, mixed. Why is this important is, which is step number 3, is you need to understand whether there is a requirement for optimization of your immunosuppression. And like you mentioned, please do not shy away from asking your colleagues. I till today am with my rheumatology colleagues anytime there is an CTD ILD with me, because biologics, kab dena hai, kitna dose, we need to understand all of this, and we have to work in the betterment for the patient. Now, considering, which is step number 4, considering everything is optimized, you know the etiology, you are following up the patient properly, but despite all of that, the patient is progressive. How? Either clinically, radiologically, or physiologically, you have that stepwise approach. Then obviously you label this as a PPF sort of a consortium, and that is when you think of antifibrotics. So this is in short, the outline of the treatment algorithm which we must follow.
That's fantastic. But in this journey, I would love to add, do not forget to, forget to, look at the routine housekeepings, the basic minimum rules of a pulmonology patient, like vaccination, avoiding smoking whenever it is required, oxygen therapy, BiPAP therapy, and also, so most importantly, start them on rehabilitation at the earliest. So unless you correctly assess and then give a 360-degree, plater, it is very, very difficult to stabilize, identify and stabilize these patients. And let's kick on to, again, the real world challenges. So let me call Dr. Ruchi. So frequency of follow-up and what defines progression. Okay, yes, we have discussed. For the sake of, reiteration, can you please throw some light, ma'am?
So the monitoring of any ILD patient includes mainly 3 domains which we usually see. We will always ask about the clinical domain, how the patient is doing. We would always look at the radiology of the patient, right? And thirdly, we would always look at the physiology of the patient in terms of the lung function testing and a 6-minute walk distance. These testing would be done at baseline. Rest all the clinical domain would be looked at each and every visit, while the PFTs would usually be repeated at 3 months, 6 months, and so forth to look at a change, unless you some changes in between. And regarding the HRCT, usually it's done at an interval of 6 to 12 months until and unless you had certain acute event coming up, like a patient presenting with an acute exacerbation for that matter, will be a candidate of repeating a radiology in between. So this is how the clinical domain, the radiological domain, and the physiological domain, which needs to be looked at, these intervals.
That's perfectly put. Okay, as Dr. Ruchi very clearly mentioned, okay, 3 to 4 months once follow-up. And whenever there is a new symptoms, we have to ensure that, we have to assess the patient appropriately. Yes, 12 months, yearly once CT is the classical thing, but not always is needed. If there is a patient is, rock stable, then probably we can, wait and watch. Okay, even you can consider repeating the CT 2 years later. It doesn't, there is no harm in it. But if the patient is, deteriorating, expressing more symptoms, probably call them for a early CT. Thank you so much, Dr. Ruchi, for a wonderful clarity. And then Dr. Arun, common pitfalls causing late diagnosis in this ILD patient.
Yeah, practical approach for a late diagnosis is most of the time we should not anchor the diagnosis. So, like I have found the sarcoidosis, I have found hypersensitive pneumonitis. That doesn't mean that we should think that all these patients behave the same. So the progression will happen in certain patient. We don't know why it happened. That still the research is going on. To relying on the same guideline should not be there. We should not fixed on to the same FEC or into the symptom based. As Dr. Ruchi said, that progression of symptoms is easy to us to just find out that yes, of course, the patient is progressing. What if the patient is having radiological worsening, but the symptoms are stable? So there are patients who have FEC of even 80%, but there will be significant progression in radiological abnormality. And most of the time, what will happen, you said, sir, in your center in Apollo, Hyderabad, you have a very good radiologist. Of course, you have a follow-up. I am also working in a corporate sector. But the problem is patient comes from all over around and they don't bring the previous CT. Sometimes they bring the previous CT. We are not able to compare exactly what exactly to the quantification of the fibrosis or something. So the practical problems are there rather than you can say pitfalls. And also we should think that anytime patient will land upon the progression and the exacerbations of symptoms should not be taken as a simple way, as you rightly said that exacerbation could be infection or something else. And even the exacerbation, as in asthma and COPD, we are saying that exacerbation brings another exacerbation. So exacerbation is the future risk of exacerbation. Here, exacerbation is the future risk of progression. So we also need to document that exacerbation in patient, that the particular patient had a previous exacerbation. So frequent follow-up should be there. So these are all the pitfalls. I can rather say that we physicians, and there is a definite learning curve that every junior should understand, that there is a learning curve for managing the ILD patient, especially the non-IPF. IPF is pretty easy. Diagnosis upfront, but non-IPF, especially the features which are not matching with the clinical radiological, there is a learning curve, and we need to take help from the rheumatologist and other senior colleagues. I personally, I still sit with the rheumatologists, radiologists, multidisciplinary team should be there so that the pitfalls can be reduced.
Indeed, I completely agree with your statement. The more you sit with your rheumatology colleagues, the more you sit with radiology colleagues, your practice is going to improve without doubt. Because many of the clinicians are hesitate to do it, and why should I go and then waste my time kind of thing. This approach doesn't work, particularly in interstitial lung disease. It is high time, go, and then we'll also party with our rheumatologists. That's more important. So, Dr. Neha, so may I ask you, what is your opinion on quantitative HRCT, artificial intelligence, and digital biomarkers? And then nowadays, any discussion is incomplete if we don't cover role of artificial intelligence. Over to you.
So, sir, they truly represent the next frontier in ILD care. And traditional, we know that assessments, they rely totally on symptoms, pulmonary function testing, and the visual HRCT interpretation, which, sometimes can, detect the progression late. So these newer tools can help us in, identify subtle structural and functional changes much earlier. If we talk about qualitative HRCT analysis, it can measure fibrosis, traction bronchiectasis, honeycombing, and volume loss, lung loss, and which the results can be reproducible. And if we talk about the artificial intelligence analysis, it can detect progression that may not be apparent to the human eye. So definitely these tools are going to help us a lot in identifying progression early. But since these are not very readily available. They are, lack of universal standardization. There is need for external validation. There are a lot of, things not available at our, general setup. So definitely these are not replacement for the traditional practice which we are doing. They are not going to replace the multidisciplinary discussion. They can be an adjunct and complementary and can help in identifying early progressive ILDs.
So brilliantly put, brilliant, no element of doubt. So as per Dr. Neha, what is very clearly visible is there's a lot of research that needs to be done in these patients. There's a lot of more guidelines, more amount of once the more research is available, then more amount of guidelines is going to add up, because AI is something, a lot of machine learning, deep learning, all these things once added to the literature, and probably maybe what I visualize is probably 5 years down the line, 6 years down the line, the moment patient is walking or wheeling into your OPD chamber, there's a red flag already on your monitor saying that this patient has got into PPF. So it is not, far off. Probably 4 or 5 years we'll have that kind of scenario. Dr. Arindam, okay, can you please throw some light on rehabilitation, oxygen, transplantation, and went to the most important challenge is it is very, very difficult to initiate palliative care discussion. Okay, what are your thoughts on it?
So I am taking it from the back. So first we need to make a concept very, very clear. Palliative care is not equal to end of life care.
Right.
So that thing I would like to reiterate again to the juniors watching this, that we have a common misconception that palliative care is end of life care. When we have nothing to do, we go for a palliative care. That is an absolutely wrong strategy. So the palliative care should start from the moment the patient goes into PPF. The patient has a limited activity, his lifestyle gets compromised. From that time onwards, the palliative things should come into play, and along with that, the patient should also be counseled. The patient should have a dietary counseling. The patient should have, if already on the patient is still smoking, anti-smoking counseling. All these things should go hand in hand, and pulmonary rehab, which should be started from the day one the patient walks in, because we have to monitor the patient's exercise tolerability. And as already discussed, that whenever we are seeing the patient might have a very poor lung function. So we must keep in mind that it should not be too much aggressive. It should be a graded lung function. And oxygen therapy, yes, it is associated with a mortality benefit. So should be discussed with the patient relatives from the very beginning, even when the patient is maintaining room air saturation, that this patient is going to desaturate at some point of time, even if the 6-minute walk test is okay. But whenever there is a 6-minute walk test, there is a desaturation, we need to consider introducing the patient to the oxygen. And we should be very clear, oxygen at what dose and for what duration. So generic oxygen prescription is not at all advisable. These things should be kept in mind. And pulmonary rehab, yeah, of course, for any chronic disease, pulmonary rehab should start from the day one, and it has got tremendous benefit on the functional status of the patient. So we should always encourage, and particularly we should have a proper team which can help the patient, including, and it does not, the pulmonary rehab doesn't mean that the patient is, we will encourage only him for exercise or breathing exercise or strength training. It is a 360-degree care. Right. And palliation is also part of it. So we need to take the relatives on board and try to make the life easier for the patient. And in standing in today's date, if we don't discuss the option of transplant to a patient of PPF, I think it is a medico-legal implication.
Negligence.
We are
medical negligence.
We are denying the patient from a potential therapy.
Right. agree with you. Each point I agree with you. My apologies. I have given you while I was talking. I have given you, impression that I was mentioning palliation as a end of life care. Again, audience. Okay, as Dr. Arindam very clearly mentioned, it is palliation is nothing but end of is nothing but its quality of life should be improved. Do not replace the palliation with end of life care. Both are extremely two different poles. Palliation should be started at the point of care where the moment you encounter a ILD patient in your OPD practice, you should start palliation. The way you talk, the way you empathize, the way you direct them. Probably when they are breathless, telling them that add a table fan by the side of you. The movement of air can decrease the breathing
Effort
difficulty
of breathing.
sensation.
Yeah.
So all these things are very, very important. And Dr. Kapil, so practically, if you see, what are the three most common management mistakes that you have seen? You being a transplant pulmonologist, you would have come across plenty of cases where there is huge amount of mismanagement happens. What is your take?
Sir, I'll tell from a practical point of view. First point which I feel is what Dr. Arun sir was saying, this MDT concept unfortunately is not at all optimized in India. It is just not being followed. Although every guideline we have been reading about this since 2015, 2016 in all the top guidelines, but unfortunately the translation at a ground level never happens. One of the reasons why we see that these patients keep on doctor shopping, trying to go to a senior pulmonologist, then a senior. But this entire MDT concept, asking help from our own senior pulmonology colleagues, never happens, unfortunately, in our day-to-day practice. So that is one thing I feel we need to improve on. Second thing, what I feel is as pulmonologists, unfortunately, when we talk about PPF, we are very, 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 considering only antifibrotics. That I feel is a mistake because we must not forget our basics. One of the points from the basics I would like to mention, which even Dr. Arindam was just talking about, is oxygen therapy. You will not believe the amount of patients who I see have not been explained the simple concept that every ILD is basically a shunt defect. When we see the paper, it's just written use oxygen at 2 liters per minute. Without a proper explanation that this is a shunt defect, the more you move, your oxygen will go down. You need to crank up your oxygen. This simple explanation is lacking in a lot of patients, and it is really unfortunate. Something so trivial and so basic as oxygen therapy is not being optimized. Third, and the final point, what I see, obviously, because I'm a transplant pulmonologist, a minuscule of these patients, unfortunately, are even given the option of lung transplantation. We talk about medically foolproofing ourselves. We talk about this being a reality or a possibility. Unfortunately, it rarely translates into traditional clinical practice, which I really want things to improve in the next 5 years.
So I 100% agree with every statement that you mentioned. But again, with 1.4 billion population and then huge incidence of interstitial lung days in Indian scenario, there is a lot as a collective force we need to do. That's why ICS is doing relentlessly, bringing up awareness on ILD, PPF, and all these minute issues. So really appreciate Dr. Amita Nene and Chawla sir and Radha Munje ma'am, for taking their time and then, giving the entire subcontinent of pulmonologists a wonderful topics of lectures back to back. And I also want to tell, that we need to, whether it is COPD or asthma, disease stabilization, kind of thing. So we bring concepts from rheumatology colleagues, and also we also bring concepts from oncology colleagues. So we need to bring the cult of conducting tumor board like that. So ILD board has to be happen. At least what we do at Apollo Jubilee Hills is monthly once we meet. Last Thursday of every month. Morning breakfast time, leisurely 8 o'clock to 9:30. We ensure that our radiologist is there, our pathologist is there, and then rheumatologist is there. So that's how we find, very clearly there is a huge impact that we are bringing into the program, ILD program in our hospital. So without wasting much time, we have only 20 minutes left. Now, please respond very quickly to the following questions. Dr. Ruchi, can you please, enlighten us where nerandomilast may fit? Probably we are just 4 months ahead of, nerandomilast launch in India. There's a huge hype is happening. What is your take briefly in 60 seconds?
So it is a newer drug which has come up for the management of IPA for that matter, and this was added in addition to the antifibrotic drugs. That is in patients who were already taking nintedanib for that matter or pirfenidone. Among those patients, Nirando was tried, and it was seen that the decline in FVC was reduced. So it can be another of the drugs as an option among these patients.
So, and as per
And
the evidence,
also in-
Fibronir, ILD, and then IPF, and then
yeah, and the
ILD
second
as well.
studies which came this
Yes,
year
second
that it
study.
also be used for the PPFs in addition to the already existing antifibrotics we have.
Yeah, at least
Right?
I was going through the literature. Looks like quite promising drug because the we can add as a second drug. One second important thing is the amount of side effects is less when compared to the pirfenidone and nintedanib, whatever it is. Thank you. And Dr. Arun, treprostinil, okay, is being labeled, okay, as per the current Teton trials, that it can be, instead of pulmonary vasodilator, we can use it as an antifibrotic as well. What is your take?
Yeah, it is actually their ad hoc basis. The previous studies where they found that in the ad hoc basis for the diagnosis, when they found out that the treprostinil was effective, at least for the PH-ILD, and then they had a subgroup analysis where they found that the FVC decline is also being reduced in the treatment arm. So they did this Treton 1 and Treton 2. And recently they published, and they, in the May 2026, they found that the rate of decline is reducing as compared to the other arm. Of course, more data is needed and still under consideration for the FDA approval. But the problem is, as you rightly said, nerandomilast, it is coming in 4 months. It's treprostinil. Again, these are all promising drugs, and at what cost? So that is the main problem for all of us. More than 70% of our patients are paying patient from their own pocket. So if they bring it in at least a reasonable price, that will be better for our patients.
Yeah, I agree with you. But just to, since you brought in the very important factor of cost, what do you expect? Because when BI launched nintedanib, I think it was the brand name was Ofev or Syndiv. Ofev, right? Syndiv. So Syndiv in Indian market. Okay. So they launched it around 1.5 lakh per month or something like that. So what is, since everyone is here, all stalwarts are here, may I ask, what should be the probably, pricing per month when they launched nerandomilast and treprostinil?
Very difficult, sir. Very difficult. When they
The
launched,
lesser the better.
yes, sir. But when they launched
Definitely.
Syndiv, very few of our patients received, and they quit the medication because of side effects, and they started blaming us. You asked us to pay for 1 lakh, 1.5 lakhs, and I have a lot of side effects. They came with the empty, so much of boxes. It came with 100. I told them to give that full box. They didn't bring in the blisters because they didn't accept for our nation. So I totally agree with you, sir. The price, we have a large base of patients. And I am already talking to based on them. We have higher population, higher base of patients. So you need to bring it accordingly. So that's
So what happens is probably till they lose their patent, okay,
The problem.
patent rights,
And the generic
okay, they
becomes
will
available,
play,
yeah.
different ball game.
That's
I
right.
don't know what to say, because a lot of research goes into it, a lot of cost involved in making the drugs. And then out of probably 20 drugs they try, probably one drug would emerge as a torchbearer or game changer kind of thing. But let's see.
Yes, sir.
And Dr. Neha, which pipeline agents are most promising quickly in probably next 30 seconds?
So a lot of research is happening. We have already, spoken about inhaled treprostinil and randomized. This one admilparant drug is coming, which is, a LPA receptor antagonist, and it is, designed to inhibit the key pro-fibrotic signaling pathways. So it is targeting one of the anti-fibrosis, targeting fibrosis through the novel pathways. Appears quite promising, but still long clinical trials to go. Another one which I am excited about is inhaled pirfenidone, since it is the same drug which we have been using from past so many years, but since it is going directly into the lungs and achieving higher concentrations in the lung with a lesser scope for side effects. So I think inhaled pirfenidone is going to be one of the important game changer drugs.
Yeah, thank you. So that again, this drug admilparant is a tongue twister. Okay, and then
Yes.
inhaled pirfenidone you have mentioned very clearly. Let's see, how far they're going to come into they perform in real world scenarios. And Dr. Arindam, so how close we are to, we talk about, precision medicine, and yes, thanks to the guidelines in Gold, GINA, role of triple therapy, role of biologicals, all those things have changed the way what we practice in the past decade, particularly in respiratory medicine. And do you see precision medicine is going to come in ILD care, PPF care as well? And if how, what is the way forward?
So it's not something we are expecting, it's something we are experiencing at present. So we have already discussed about quantitative CT and all those things. So if we are looking at the PPF, we are looking the behavior pattern of the disease. So it is basically the trajectory of the disease. So predictive models are something which can help us to predict which patient is going to behave how, such as a rapid decline in lung function, rapid progression on CT. All these things help us to deduce a predictive model from which we can isolate that these patients are going to deteriorate rapidly, and we need to look deeper into those subset of patients. So as far as the circulating biomarkers are the next in thing, so and also the pharmacogenomics is going to play a big role in it. So we have already known that few genes like the MUC5B or TET and all these genes play a role in the pathogenesis. So as this basic research is coming out, and with pharmacogenomics into play, we will be able to identify that which drug can work better in which subset of patients, and also which exact pathway is responsible in which subset of patients, thereby opening more targets for the therapeutic trial. And also that with we can find out that there are circulating biomarkers like the CCL18 or the KL17, something like that. These are all those in the investigational stages. I think with time we can have a easy to use or monitor or predict things based upon this circulating biomarkers. So that is something really interesting field going to be unveiled in the future.
Yeah, thank you, Arindam, for that clarity. I would love to add one more point. See, my dear friends, if you test probably a young onset progressive pulmonary fibrosis patient or young IPF patient, if you identify associated MUC5B gene issue or telomere biology, to be honest, probably not even 0.1% of patients we are testing as of now in India. We should test it, because why should we test it means there is enough literature now available. So in these kind of patients, if you hit them with steroids, the fibrosis is going to progress rapidly. So you should limit usage of steroids in these patients. Like that, we're going to have a lot of as the literature evolves in the next probably 5 to 6 years, we may have a lot of clues of practicing precision medicine in interstitial lung disease. And my dear delegates, okay, whoever watching, we have another 7 minutes to go. I'll take up, summarize your questions as well. Many hundreds of questions have come, but I'm summarizing them parallelly using AI. Okay, I'll come back to you. Whichever questions I have not we have not covered, we'll definitely answer tonight. It may take an additional 5 minutes. We'll cover it. And Kapil, and the development most likely to transform the progressive pulmonary fibrosis management in next probably decade. What do you see? How do you see?
So if you ask me only one, I will say nerandomilast, because that is something which is on the horizon in the next 4 to 6 months. Is something which is supposed to be launched in India. Now, how far will it actually change PPF in India? That is obviously something which is left to see. So let's see how it does. And obviously, inhaled pirfenidone, treprostinil, all of that is obviously waiting. But if you ask me one, I will say nerandomilast.
So other important thing, my dear friend, if you see the various literature, I'll give you an analogy. So the usage of low tidal volume ventilation in ARDS management. So that's an established guideline probably 30 years back in the West. But to translate into the developing world, particularly India, Africa, and probably Southeast Asia, China kind of thing, it takes the evidence says at least 2 decades to translate into, to reach into the lives of the point of care patients. So another important thing is we need to talk more regarding PPF. We need to talk more regarding, the evidence behind management of ILD patients. That's also, I think, a game changer. More we talk, more we become, comfortable in managing these patients. And let me pull out the questions. First of all, I must appreciate many people, Dr. Arvind, Dr. Deepa, Dr. Vinay from Jodhpur, Deepa from Madurai, Dr. Arvind from Kochi, Dr. Harish from Thrissur, Dr. Sunita from Faridabad, Dr. Nisha from Vijayawada, Dr. Samir from Udaipur, Dr. Divya from Salem, Tamil Nadu, Dr. Amit from Thane, Dr. Neha from Navi Mumbai, Dr. Rohit from Gwalior, Dr. Sneha from Kolhapur, Dr. Preeti from Agra, Dr. Sunita from Faridabad, Dr. Rekha from Mangalore, Dr. Hemant from Siliguri, and my good friend, Dr. Shalini from Ranchi, Dr. Monica from Jammu, Dr. Vivek from Chandigarh, Dr. Anjali from Hyderabad, Dr. Nitin from Nagpur, Dr. Swati from Indore, Dr. Manish from Surat, Dr. Ritu from Bhopal, Dr. Rakesh from Guwahati, Dr. Sonal from Vadodara, Dr. Vinay from Jodhpur. They have all contributed for a lot of questions. And before concluding, taking concluding remarks, probably I would love to ask, in which patients of CTD ILDs, you would love to biopsy using cryolung biopsy, which is the state of art right now if we are contemplating a biopsy. Who wants to take this question? Anyone? Kapil?
Sir, I don't think so. It is a vertical subtype, but I believe if you have got enough evidence of clinically to mention that there is a proper CTD, let's say there is an established scleroderma or something having
Right.
features, I don't think so there is much need of us to biopsy to show that, or to prove or disprove that this is it. But sometimes when you've got all these rare myositis markers, sometimes it comes positive. It's very unsure as to what it is. You might go in for that.
Other practical problem, Kapil, myositis profile also, it doesn't come easily. It takes 3 days, 4 days. Some cities, it may take 1 week, 10 days for the reports to come. Meanwhile, probably you may end doing a biopsy. But someone was asking whether surgical lung biopsy is preferred or cryolung biopsy is preferred. The guideline is very clearly, if it is CTD associated ILD or there is no role of biopsy at all. A good quality of HRCT is good enough. we don't need to subject them to biopsy. And there is no role of nowadays with the advent of a lot of good quality of HRCT machines and a good amount of knowledge to diagnose these interstitial lung disease. Surgical lung biopsy doesn't have any role, very, very least role. Most of the things we have covered in the talk, and all great things, whether, okay, good quality discussions like this, whatever is, will have to come to end, because each one of us, have to go to bed to start working tomorrow, and no doubt about it. Profusely thank Lupin for being the partner, okay, in disseminating such a useful information across the subcontinent. This is going to stay in YouTube as well for you people to refer, reread again and again. And then I profusely thank Dr. Amita Nene, Dr. Chawla sir, and then Dr. Radha Munje ma'am, and then entire team for their relentless effort in disseminating the knowledge. And the most important is, they choose the topics which have highly practical impact. So like today's progressive pulmonary fibrosis. And then I thank Dr. Kapil for his wonderful talk, Dr. Ruchi for Ruchi, Dr. Arindam Datta, Dr. Neha, Dr. Arun for their very, very, excellent practical points, bringing in practical points in discussing this wonderful progressive pulmonary fibrosis. And then thank you, technical team. And with this, on this auspicious Guru Purnima, once again, salutations, salutes to Guru. And then I pray Guru to, give us that amount of compassion, that amount of, wisdom to ensure that we will do nothing but evidence-based medicine, and then most practical approaches to be delivered to the patients whom we treat. They are also our living gods. Okay. So with that, I would love to close the webinar. Thank you.
Thank you, sir.
Good night.
Thank you so